wa barakatuh. It is 7 p.m. here in Abu Dhabi. Hello and welcome to another educational night on cardiac amyloidosis, brought to you by the Imaging and Heart Failure Working Groups of the Emirates Cardiac Society. My name is Firas Al-Badareen. I'm a cardiac imager and cardiologist in Cleveland Clinic, Abu Dhabi, and I'm the head of the Imaging Working Group of Emirates Cardiac Society. I would like to welcome each and every one of you and thank you for taking the time to join us on this educational event that is brought to you by Emirates Cardiac Society. It gives me a great pleasure also to co-chair this event with my colleague, Dr. Nadia Al-Matroushi, who will introduce herself. Dr. Nadia.
Thank you, Dr. Firas, for the kind introduction. My name is Dr. Nadia. I'm a consultant cardiologist and medical director of heart transplant, Cleveland Clinic, Abu Dhabi. I'm also lead of the heart failure working group in the Emirates Cardiac Society. It's my pleasure today to welcome you all for the first joint meeting, heart failure and imaging working group. Today we'll be focusing on the diagnosis and the treatment of cardiac amyloidosis. We are fortunate to have with us today some of the leading experts in the field, and especially in the amyloidosis. So thank you again for joining us. And Dr. Firas, you have the first, maybe you can start the first session.
Absolutely. A couple of housekeeping issues before we start. The meeting is going to be recorded. Please make sure your lines are muted. There is a chat box. Please feel free to send any questions you have in the chat. We'll go through the first presentations and then we will have a Q&A period. This is a CME accredited event. Make sure you follow for the links after the event to claim your credit. So without further ado, we'll kick off this star-studded event. We'll kick off the first session, which focuses on contemporary diagnosis and treatment of ATTR cardiomyopathy. And the first presenter is my dear friend and colleague, Dr. Ramzi Tabbalat, who will be discussing extracardiac manifestations of ATTR cardiomyopathy. Dr. Ramzi is the director of Al-Abdali National Amyloidosis Center in Amman, Jordan. He is a well-renowned cardiologist with expertise in multiple areas, not the least of which is ATTR cardiomyopathy. Dr. Ramzi?
Firas, thank you. Nadia, thank you very much for inviting me to be a part of this program. It's my pleasure and my honor to be with you tonight. I don't know if you can see my slide. Can you?
We can, Ramzi. Go ahead.
Okay. So my task tonight would be to discuss the extracardiac manifestations of ATTR cardiomyopathy. So I'm going to just present you with a case from our center here in Amman. This is a male, 61-year-old male patient who is a smoker. His first presentation to us was on July last year, and he presented with 3 months history of sensory neuropathy. So he was feeling numbness in his fingers and also in his toes. With that, he was also complaining of orthostatic hypotension. So he actually was worried about his symptoms because they were progressive. They were getting worse with time. And for that, he saw many physicians from different specialties, including neurologists. And even he had to visit a hospital in Germany seeking help and advice. But there was no diagnosis for his symptoms. In his past medical history, he had a history of spinal canal stenosis, for which he had a lumbar disc surgery 4 years previously. And also when he came and saw me in my office, he had his right hand and wrist bandaged because of a carpal tunnel surgery that he had 3 days prior to seeing him in our hospital. So with this constellation of symptoms, we actually had a high suspicion of amyloidosis in this patient. So we did the workup, which I will not discuss because this is not what I'm going to discuss tonight, but we did what we usually do when we suspect amyloidosis, is that we do an ECG, which shows low voltage here. We also did an echocardiogram, and as you can see, there is concentric left ventricular hypertrophy involving the left ventricle. There's also thickening of the aortic valve and maybe the mitral valve. And we did a global longitudinal strain, which shows apical sparing, which is very characteristic of amyloidosis. And we followed that, of course, with a PYP scan, radionuclide imaging for amyloidosis, and it was grade 3 positive. The MRI was also very suggestive of cardiac amyloidosis, with an increase in the native T1 numbers and also an expansion of the extracellular volume up to 43.7%, which is abnormal. So all of this, of course, with the blood test to rule out AL amyloidosis, confirmed the diagnosis of ATTR amyloidosis. One test that we always do in these patients is we do the genetic screening for sequencing for such patients to make a distinction between the wild type ATTR amyloidosis and the variant or hereditary type of ATTR amyloidosis. And his results came back showing that he had the V50 MET mutation, which is probably the most common in the world. Now, Val50 MET comes in two forms. One is the early onset, which predominantly presents with neurological features. And also we have the late onset, which presents with a mixed phenotype, neurological features, and also cardiac features. Now, he is 61 years old, so he is in the late onset. The age of 50 is what distinguishes late from early onset. So he was a late V50M late onset patient. Now, as you can see here, this is just to show you that patients who are diagnosed with the variant or hereditary type can present with different phenotypes ranging from purely cardiac features on the right side of the slide to purely or predominantly neurological features. But the majority of these mutations, they have a mixed phenotype with some cardiac manifestations and also some neurological manifestations. Now, the reason I started with this case is just to show you that we are probably in our part of the world, we're different from the prevalence of the two different types of ATTR amyloidosis in different parts of the world. Now, we started working on amyloidosis back in 2021, and since then we've had evaluated 82 patients between males and females, and as you can see here, they come from different countries. Now, most of our patients, they come either from Jordan or from Iraq, but we also had patients coming from countries in the Middle East like Libya, Saudi Arabia, Sudan, Palestine, Syria, Yemen, and Algeria. And if we look at the diagnoses that these patients had, we actually diagnosed cardiac amyloidosis in a good number of these patients. What AL amyloidosis was diagnosed in 18 patients. Cardiac amyloidosis was ruled out in 27. 19 patients had ATTR variant, the hereditary type, and 5 patients had the wild type. Now, this is different from other parts of the world where the wild type of ATTR amyloidosis is more prevalent than the hereditary type in a ratio of about 4:1 or 3:1. Here in our center, we can see that that 80%, almost 80% of patients presenting with ATTR amyloidosis had actually the variant type. So with the knowledge that patients with the variant type present with not only with cardiac manifestations that we're used to see in patients with the wild type ATTR amyloidosis, now we have to also deal with patients who may not present as an initial presentation with cardiac manifestations, and their initial manifestations may be neurological or extracardiac. So in that case, we have to pay a lot of attention to the complaints of our patients and think about amyloidosis in every patients who present with neurological manifestations and other extracardiac manifestations. Now, if I go back to the previous slides, you can see that we had patients who had the TATA, 12 patients out of 19 patients. We had different other mutations, the VAL142I, which is the predominant in Black Americans and also people of African ancestry. The VAL50 like our patients. And let me just say that this was the first Jordanian patients diagnosed with hereditary type ATTR amyloidosis. We also had the S43A, and we have 2 tests that are pending on 2 patients who have very likely have ATTRB. We also perform carrier screening. We did that on 15 patients, which was positive in 11 patients. So we had a number of mutations, most predominantly the T80A or the T60A mutation, which is the predominant mutation in patients coming from Iraq. So you can see that the mutations that we saw in Jordan, in patients not only coming from Jordan, are predominantly these types. And in these patients, the presentation is usually a mixed phenotype between neurological manifestations, which I will explain now, and cardiac manifestations. So you can see that cardiac amyloidosis is not only a disease that is restricted to the heart, where patients will come in with cardiac manifestations, but they come with other manifestations that are not cardiac, and these manifestations may precede the onset of cardiac symptoms. And that's why a lot of these patients are typically missed. They spend a number of years going from one specialty to the other, from one physician to the other before they get a final diagnosis. This slide shows you the typical delay from the onset of symptoms in these patients and the time of diagnosis. And it's usually on an average between 3 to 4 years. So patients go around for 3 to 4 years seeking an advice, seeking a diagnosis to their symptoms without, without having that diagnosis until about 3 to 4 years past. And this is a very crucial, very long time in a patient with amyloidosis, because we know that this disease is progressive and that any time that is wasted will affect the quality of life and eventually the survival of these patients once they're diagnosed. So it's very important that to keep amyloidosis in our minds, so that when we first see the patients, that the time between the first encounter of these patients with us as physicians, it can be as short as possible. So when we talk about extracardiac manifestations, as you can see in this slide, we're talking about a lot of symptoms. If we talk about cardiac, a lot of these patients will present with heart failure symptoms. Sometimes they present with atrial fibrillation, conduction abnormalities. Musculoskeletal symptoms, they can have pains in their shoulders, in their knees, and also in their hips. And some of these patients would even undergo surgeries for these joint problems. Ruptured biceps tendon is one of those signs that are described in patients with amyloidosis. And I have a picture of a patient who had a rupture of the biceps head. Now, these patients, when their arms are extended, they have normal arms, but they flex their arms. Instead of seeing the nicely rounded biceps muscles in their arms, you see a ball. And these patients think that they're having, big muscles. In fact, they're having a rupture of the 1 or 2 heads of the biceps, and that's what causes the biceps muscle to just crumble and appear like a ball in their arms. So this is, we don't see that very often, but when you see it, it is very suggestive of the presence of amyloidosis. They can also have trigger fingers as part of the amyloidosis involvement. Carpal tunnel syndrome, which I will come to in a little bit, is also a very important symptom or a very important problem that these patients might have. And I will show you some more information about this. Back pain due to lumbar spinal stenosis, this is often described. You can have amyloidosis deposition in the spinal cord causing stenosis of the spinal canal. And this will cause symptoms that are similar to patients who are having lumbar disc disease. We often ask our orthopedic surgeons when they perform surgery on these patients to take a small piece of the ligamentum flavum, which they typically remove during surgery, and to send that for Congo red and subsequently for amyloidosis typing if the Congo red stain is positive. If we go to the gastrointestinal tract, they can have a lot of these patients who have the variant type can present with chronic diarrheas. This is a common symptom in these patients. And it is not because of direct involvement of the gastrointestinal tract. It's actually because of the autonomic nervous system disturbance that occurs in these patients, causing them to have recurrent, long-standing diuresis that is sometimes debilitating in a lot of these patients, causing a lot of electrolyte abnormalities and also wasting, responsible for some of the weight loss that these patients have. Early satiety, also they always anorexic, leading also to significant weight loss in these patients. And I've seen patients who have lost 20 to 30 kilograms in a span of 6 to 12 months. So the patient will, when they first appear in their office, they look emaciated, they look like they've starved and they haven't had food for a very long time. Intolerance to blood pressure medications, hypertension is a common disease in this patient's group because of their age. And oftentimes the patients will tell you that when they started feeling these symptoms, they were on 3 or 4 blood pressure medications, and they had to gradually withdraw from these medications because their blood pressure keeps coming down, and eventually they may even stop these medications, and they will think that their hypertension is cured. It's actually not cured. It's just because they have significant involvement of the nervous system that their blood pressure starts to come down. And with the drop in their blood pressure, they will have significant orthostatic hypotension. When they're supine, their blood pressure may be okay. When they stand up, their blood pressure will significantly drop. And we always perform orthostatic blood pressure measurements in these patients because eventually they're going to be on a lot of medications that cause lowering blood pressure. So if you don't pay attention to their supine and standing blood pressure differential, you might cause even more problems to these patients. Peripheral sensory motor neuropathy. This is the symptom that brings a lot of patients to the attention, and it is part and parcel of most of variant hereditary ATTR amyloidosis. They will get neuropathic pain and numbness in their feet and in their hands that is progressive. This will be associated with muscle weakness, and that is also progressive. And in a lot of times, it leads to the patients being confined to the wheelchair, to beds. And also sometimes they have a tendency to fall down, and they have real difficulty in walking when they have a progressive disease. Autonomic neuropathy will present with orthostatic hypotension. As I said, sometimes these patients will have urinary incontinence, will also have erectile dysfunction, in addition to the chronic diarrhea that you see with these patients as a result of autonomic nervous system involvement. Now, carpal tunnel syndrome, I specifically will talk about this in the next few slides. It is often bilateral. Now, the important thing about carpal tunnel syndrome is that the carpal tunnel symptoms can precede the onset of ATTR amyloidosis in 5 to 8 years. So it gives you a window to make an early diagnosis of the disease long before it manifests in cardiac or extracardiac manifestation. So patients who come complaining of carpal tunnel syndrome, especially if it's bilateral with no cause or reason for this carpal tunnel syndrome, these symptoms can be a prodrome or an early manifestation of ATTR amyloidosis. And we often ask these, we ask our orthopedic surgeons whenever they're performing carpal tunnel surgery to get a specimen of a tissue from the surgery, and we send that for Congo Red, and if it's positive, we do tissue typing in these patients. And we've picked patients who've only come to the hospital to have a carpal tunnel surgery. We've diagnosed some patients with amyloidosis. Now, why carpal tunnel syndrome is important? Because if you look at this study here, they took patients who had carpal tunnel disease and surgeries, and they followed them, and they compared them to patients who had no carpal tunnel disease or surgery. And during the follow-up of 12 to 15 years, they found that more patients who had carpal tunnel disease had amyloidosis during follow-up, with a hazard ratio of about 12 to 1. And also, if we look at the cumulative incidence of heart failure, there were more heart failure in these patients, more atrial fibrillation prevalence in these patients, and also more conduction abnormalities and the need for implantation of ICDs and pacemakers in such patients. So if you have a patient who's diagnosed with carpal tunnel, especially if it's bilateral carpal tunnel with no reason, these patients should have a biopsy during the time of surgery. And if there is no biopsy, you should follow them up for the possibility that they may develop ATTR amyloidosis in the future. This is courtesy of Dr. Hanna from Cleveland Clinic, who is very interested in carpal tunnel as it relates to ATTR amyloidosis. And in the Cleveland Clinic, they followed these patients. And this is just one particular patient from this series who had a carpal tunnel surgery in the year 2016. And when they did the congruent stain, it was positive. At that time, the congruent stain was positive, but they did a PYP scan on this patient, and the PYP scan was negative. And the GLS and the echo was also negative. The LV wall thickness was only 0.9 centimeters, and the NT-proBNP was normal. So they followed such a patient, and in 4 years, in 2020, his PYP scan is now positive. Still, he did not have apical sparing. Still, he did not have left ventricular hypertrophy, and still his BNP was normal. But this patient has uptake, indicating that there is amyloid deposition in his heart. So now we're hoping to be able to make a diagnosis of ATTR amyloidosis long before it manifests clinically with left ventricular hypertrophy and also with deterioration of the function. So neuropathy, polyneuropathy in such patients.
1 minute, please.
Yes. Polyneuropathy in such patient is a very important symptom. And for that reason, there is now this kind of algorithm where if you have idiopathic, rapidly progressive sensory motor or sensory neuropathy, with one or more of these symptoms, you have to really suspect amyloidosis. There's a family history of amyloidosis, bilateral carpal tunnel syndrome, autonomic dysfunction, gait disorders, unexplained weight loss, cardiac hypertrophy, vitreous opacities, or even renal abnormalities. This is a slide from the Pavia from Dr. Paolo Milani, and it shows you that even in Italy, the extra cardiac manifestations of such patients presenting with ATRV are almost similar to what we see in this part of the world. I just put this slide just to show you two specific signs that we see with AL amyloidosis, because these are signs that even if you sit in front of the patient and you see them, that is almost pathognomonic. They're almost pathognomonic for AL amyloidosis. And that is the macroglossa and also the periorbital ecchymosis, or discoloration of the eyes. This is very specific, very pathognomonic for AL amyloidosis. When you see them, you can swear almost 100% that these patients have AL amyloidosis. So it's like, you know, looking for amyloidosis, and I'm down to my last 2 slides for us, so I'll be done in about half a minute. So, you know, when we think about amyloidosis, it's like trying to find the zebra between a herd of, you know, wild beasts trying to cross the Mara River in Africa. And if I tell you that there is a zebra in this picture, you probably won't believe me, and it would be very hard for you to find it in this you know, mass of animals. But there is a zebra here, and here it is. And this is how you this is why you have to suspect amyloidosis and try to find it between you know, a whole lot of symptoms that seemingly may not be related to each other, but definitely they are related. And that's why, again, when you screen patients for amyloidosis, if you have a patient and you're doing an echocardiogram and you detect an LV wall thickness of 12 millimeters or more with no specific loading condition like aortic stenosis, hypertension, if you combine that with any of these symptoms, then the likelihood of ATTR amyloidosis is extremely high. If we this is my last slide, if we go back to our patient, you can see that this patient who presented with the constellation symptoms had a lot of those red flags that are associated with ATTR amyloidosis. He had the sensory neuropathy, he had the orthostatic hypotension, he had spinal canal stenosis, and very recently, just prior to his presentation to our center, he also had surgery for his carpal tunnel. So I had 1, 2, 3, 4 red flags that are indicative of amyloidosis. And as Machiavelli said once in 1500, at the beginning, a disease is easy to cure, of course, because it's still the beginning of the disease, but difficult to diagnose. As time passes, not having been treated or recognized at the outset, it becomes easy to diagnose, but difficult to cure. We're hoping that we'll be able to catch our patients early in the disease before the symptoms progresses to a more difficult disease to treat. With that, I really thank you very much for the opportunity to talk, and I'll be more than happy to take any questions. Thank you.
Thank you so much, Ramzi. That was absolutely fascinating, and the last few words were actually make perfect sense as a nice segue to the next topic. Is how do you diagnose cardiac amyloidosis, ATTR cardiomyopathy, especially in the current era of non-biopsy diagnosis? And to discuss this in more detail, I couldn't think of anybody better than Dr. Khalid Naji from Prince Sultan Military Medical City in Riyadh, Saudi Arabia, who is a cardiologist and multimodality cardiac imager, a man of many hats, who will be able to provide us how do you perform imaging diagnosis of ATTR cardiomyopathy. Dr. Khalid, the floor is yours. Dr. Khalid, I think you're on mute.
Sorry. Thank you, Dr. Firas, and I'm glad to join you tonight in this lovely night, and I hope your audience will take some messages from my talk today. So today, my goal is just to simplify the approach to the diagnosis of amyloidosis. And the good thing that for now, since we have this advances in the cardiac imaging, we can diagnose patients with amyloidosis without the need for biopsy. So I will just focus on the basic idea of the cardiac imaging and the role of cardiac imaging in diagnosis of amyloidosis, and I will keep it simple. So every cardiologist and the heart failure specialist will know exactly what he is looking if he is requesting echo or nuclear scan or MRI or other imaging diagnostics. So in the echocardiography, usually what we are looking for is the classic findings of amyloidosis. For example, if you can see here in the echocardiography, we can see there's diffuse thickening of the LV, RV, the LV cavity, RV cavity, they are small. There is biatrial enlargement. This is the classic teaching of amyloidosis. But remember, not all amyloid patients, they have the same picture. Also, what we are trying to see if there is any left atrium thrombus, thickened valves, some pericardial effusion, and restrictive pattern in the tissue Doppler velocities. But remember that these findings are sometimes not early, not specific, not sensitive. And if you wait these findings to happen, for example, if you are waiting your patients to have very thickened left ventricular wall, especially more than 12 or more, maybe sometimes it's too late. So we have difficulty in the echo just to diagnose your patient in the right time. So here you can see again this thickened LV, you can see the thickened walls, the abnormal tissue Doppler velocity that keeping with the restrictive pattern. And when we apply something called the speckle tracking echocardiography, especially when we do the strain analysis, what we focus on is the longitudinal shortening and radial shortening. So amyloid patients, typically they have reduced strain analysis in their echo. So if you can see here, this is the normal strain analysis, and amyloid patients usually they have reduced longitudinal strain analysis, and they give this typical feature of a Sheridan top pattern on echo. But the problem with the Sheridan top, remember that it is not specific. So many patients, they can have this pattern, but when you do investigation by imaging or biopsy, they don't have the amyloid. So in this slide, just what's the finding on echo. I cannot go to all details because I have just 15 minutes to finish. The next thing, when you do MRI, the MRI is a great tool for diagnosis. It can give us the ability to do tissue characterization using the T1, T2, and the extracellular volume. So I will try to make it very simple. Every cardiologist, what he should know or what he should ask the cardiac imager to tell him. So what we are doing in MRI, we are quantifying something called T1 mapping, extracellular volume, and assess the late gadolinium enhancement and myocardial nulling. What I want you to know if the late gadolinium enhancement is keeping with amyloid or not. The classic teaching or finding for amyloidosis is to have this diffuse subendocardial LGE or transmural, as you can see here in the images. And this is maybe more of cardiac imaging experts, but we sometimes patients with cardiac amyloidosis, they have this difficulty in nulling their myocardium because there is a lot of disease and like fibrosis in their myocardium. And regarding the sensitivity and specificity of the MRI in amyloid, actually MRI is doing good job, and it have like a sensitivity and specificity of 85 to 92%. And the MRI also will be good if you are questioning your patient, does my patient have amyloid or other cardiomyopathies? So the MRI will tells you actually by using the CINI, the T1, and the fibrosis, it can give us different patterns for different cardiomyopathies. But remember that if your patient is having amyloid, usually they have this diffuse fibrosis, subendocardial or transmural, and their T1 map and ECV usually sky high, like the T1 will be around 1200 or more, or the extracellular volume usually be high, at least 40 or above. And sometimes if your patients have advanced CKD and you are afraid to do, to give the patient actually contrast, there was a nice paper tells that, but just by using the T1 map and the T1 map was very high, you can say your patient most likely have amyloid, but typically in reality, we need more than one finding to confirm diagnosis. For example, you can do the MRI and BIB scan. This slide will show you some of the typical findings in the MRI. The next thing is the radionuclide imaging, and actually we are putting a lot of money in using the BIB scan because the BIB scan or nuclear scan, it has very high sensitivity and specificity. Most of the time we are using the bone-avid radiotracers, but I think in the near future, we'll have more options, for example, PET scanning or autonomic myocardial innervation imaging. So regarding the bone-avid radiotracers for cardioscintigraphy, we know that the bone-avid tracers, like the BIB scan or other tracers, it for unknown reason, or we not fully understanding why patients with amyloid, they have this uptake, but amyloid patients, they tend to have uptake in their myocardium with high sensitivity and high specificity after we excluding the AL amyloidosis. So in one study, it showed that the BIB scan, it has the sensitivity and specificity that's close to 98 and 100 after you are excluding the AL amyloidosis by sending the blood workup. This is the general approach for how you should read your BIB scan. I will show you in the next slides. So simply, you should ask the cardiac imaging or your radiographer, the radio imaging colleagues regarding two things. What's the grade of the uptake, and if the uptake is inside the myocardium or not. So usually to say this patient has a positive scan, the grade should be at least 2 or more. So simply, if you look to the images by yourself, if the myocardial uptake is at least similar to the ribs or more than the ribs, this is grade 2 or more. For grade 0, less likely your patients will have amyloid. And grade 1, sometimes it can be because of AL amyloidosis or other causes, and sometimes it needs more investigations like biopsy. So this description is mainly for qualitative assessment. We have quantitative assessment when we assess the uptake for the over the heart itself and the contralateral heart. But for now, maybe the qualitative assessment mainly is doing the job, and the quantitative assessment, sometimes it can give us false positive because the uptake sometimes it is in the blood pool activity. So make sure your patient is doing the nuclear scan in addition to CT to make sure that the tracer you see is inside the myocardium. So if you can see here, the uptake, you can say this is maybe grade 2 or 3 or more, but when they did the SPECT CT, you can see the whole uptake is in the blood pool activity. It's not in the myocardium. So this is false positive. But another example of patients, you can see clearly the uptake is inside the myocardium, and by using SPECT CT again, you can see the uptake is inside the myocardium. And in my experience, like at least 2 or 3 patients were labeled with cardiac amyloidosis based on BOIB scan. And when I check the images by myself, I found the uptake just blood pool. So make sure that whoever read the imaging, he knows what to do. And sometimes just to confirm the diagnosis, we need a biopsy. But with the BOIB scan, with the high sensitivity and specificity of the BOIB scan, the need for biopsy is much less nowadays. But the SPECT scan or the bone avid SPECT scan, sometimes it lack the ability to quantify the amyloid, or sometimes if you want to monitor the patients. That's why there is a lot of investigations regarding using another tracers, for example, the PET scan. But I think it's most of them is still under investigation and it's not widely available. And I think in Saudi Arabia and Emirates, what's available now is the BOIB scan. Regarding the autonomic myocardial innervation, what you just know that there is something called just autonomic myocardial innervation, and the idea here is just if your patient have problem in his innervation in the scan and there is no much uptake with this scan, that means there is autonomic myocardial abnormality, and this patient maybe have higher risk for heart failure symptoms or arrhythmias. But clinically, we don't use it a lot, and but it's good to know about it. Just a few slides regarding the role of cardiac CT. I think this for sure is coming in the near future. And the idea that if your patient have claustrophobia or he has cardiac devices and he cannot do the MRI for any reason, we can do cardiac CT with special sequences. And we can quantify what we call the extracellular volume, the same idea we do with the cardiac MRI, but quicker, and it can tell us many informations, almost the same MRI. So I think in the next years, we'll do the cardiac CT and quantify the extracellular volume, same as the MRI, and can help us to differentiate between different cardiomyopathies. For example, imagine if you can do the CT and quantify the ECV for TAVI patients as screening without giving your patient any extra radiation or contrast. The next question, can we follow our patients with a different imaging modality if we start treatment? The early to say yes, but there is some reports from different imaging modality to suggest the use of echo. For example, if your patients have recovery in ejection fraction or recovery in his strain for sure over years, this is a hint or clinical evidence that your patients maybe benefit from the treatment. So if you can see here, there is reduced global longitudinal strain, and with time over years, there is improvement in his strain analysis. The same idea with the MRI, if there is improvement in the T1 mapping and ECV, and for sure it will take years, that means your patient most likely benefit. And there is few reports describing resolution of the BYB scan uptake, again, over years, but we don't have a lot of evidence to suggest or recommend this kind of follow-up, and hopefully with in the near future, we can have some answers and some guidance. Here is just slides how we define the response. Still, there is no much evidence regarding the use of these imaging modalities, but what I will advise, just assess your patients, clinically, check his biomarkers, and if there is improvement in his strain analysis, you can repeat the MRI after 2-3 years, check his T1 mapping and extracellular volume. I will skip some slides here. Here is some recommendations regarding the use of cardiac imaging. It was from papers written by Sharmil Drabulla and her colleagues. Just one thing here, just sometimes the imaging can mislead the physician. So use always your clinical sense. This is a case report regarding young patient. He was 32 years old. For some reason, he has LVH. They did for him BYB scan. It was positive. They did for him MRI. It was normal. So there's conflicting data. So sometimes for some with like we cannot explain it. The BYB scan can have this positive uptake, but it doesn't correlate with your patient. For example, 30 years patient, why he has amyloid. When they did the biopsy, it came back negative. So the message from this case report, if the imaging finding either like positive or negative doesn't correlate with your patient, don't hesitate to send your patient for a biopsy. This is a nice paper. I recommend all of you to read it and just to help you and guide you. And thank you.
Thank you so much, Dr. Khalid. That was tour de force on the role of imaging. A lot of data and a lot of information. I'm hoping we can clarify some of this and kind of distill it into some take-home messages for the audience in the Q&A session. Moving along, so now through the journey, you've suspected cardiac amyloid. Dr. Khalid taught you how to diagnose it. Now, how do you treat these patients? The next two sessions are going to talks are going to be how do you treat a patient once you make a diagnosis of ATTR cardiomyopathy. The first of these two is going to be by Dr. Ammar Chowdhury, a close friend and colleague who is an advanced heart failure specialist from King Faisal Hospital and Research Center in Jeddah. Dr. Ammar wears a heart failure hat, so he's going to tell us what should a heart failure physician do to treat these patients. Ammar, take it away. You're mute.
Thank you very much. Yeah, I'm just.
Ammar, you're muted again.
Sorry about that.
We really want to hear you.
Yeah, right. You got me there. Thank you. So I want to thank the organizers again for this opportunity. So the treatment part, as you mentioned, there are two sections. Professor Perlini will cover the disease-modifying therapies, whereas I'm going to talk about the general management of heart failure using conventional treatment options. And the fact that we have disease-modifying therapies nowadays, and there's a lot of excitement in that space, is an acknowledgement about the failure or lack of success of conventional strategies for managing cardiac amyloidosis. But I want to highlight through this slide the current status and the evolving outlook for ATTR-CM. So this is sort of the result of the recently published HELIOS-B trial, which looked at the utility of vutrisiran versus placebo. Vutrisiran is a gene silencing therapy, and it showed an improvement, dramatic improvement in the composite endpoint of death or recurrent cardiovascular events in comparison to placebo. But still, the rate of the primary composite endpoint was 40% by around 3 years. So even in the setting of a clinical trial where patients were detected relatively early, there was a substantial residual risk. And this residual risk of death and heart failure morbidity has to be managed through the conventional tools that we have. Even if they are not very perfect, we have to employ them in the best way possible. I would argue that that starts with building bridges with your patient and their caregiver, making sure that they understand the disease, so they are engaged thoroughly in the treatment plan and have sort of a plan B if things don't go according to expectations. So set the expectations early on. And one thing that might help you in that is to prognosticate individually how your patient is going to do. What we can use for that is the staging scheme, either the Mayo Clinic staging scheme or the National Amyloid Center staging scheme. Both of these schemes employ simple tools. They both use two criteria, NT-proBNP cutoff of 3,000, and the Mayo Clinic uses, in addition to that, troponin elevation. The National Amyloid Center staging scheme uses, in addition to the NT-proBNP, a reduction in GFR to less than 45. So if your patient has two out of these criteria, both of them, using either one of the schemes, their median survival, expected survival, is only 2 years. So that variety heart failure, and the prognosis of this patient is worse than many of the aggressive cancers. Mind you that these schemes were developed before the widespread use of disease-modifying agents, and there could be other prognostic markers such as the use of diuretics, the dose of diuretics, atrial fibrillation, and whatnot, and some imaging techniques as well. But this is sort of a quick and dirty way to find out how your patient might do and sort of anticipate having a plan for advanced therapies if indicated early on. So you need to approach this with that psychosocial support. Don't forget about genetic counseling and screening. Now, with respect to pharmacotherapy, that is going to be employed, and it's better to deliver that through a dedicated clinic like a cardiomyopathy or a heart function clinic, where objective tests can be done to assess the progression of the disease using quality of life metrics like the KCCQ score, the 6-minute walk test. These can be done on a biannual basis. You need to also have a nurse or a coordinator who's going to organize all those referrals, given the extra cardiac manifestations of this disease, and expect frequent follow-up and frequent problems that are going to arise during the patient's journey. Managing volume remains the cornerstone of cardiac amyloidosis treatment. And this is data from the National Amyloid Center, looking at 22 years worth of experience. And loop diuretics were by far the most commonly prescribed medication. Close to 80% of patients received loop diuretics, far more than any other therapy. Yet the recommendations are largely empiric. There's no high quality randomized clinical trials in this space. One of the key limitations that we know about using diuretic therapy is the fact that the walls are thick, the ventricle wall is thick, the LV is non-compliant, the LV cavity is small, so the stroke volume tends to be on the smaller side. It doesn't tend to vary much, so usually the stroke volume is fixed. So if you under-diurese your patient, they're going to rapidly develop congestion. If you try to achieve euvolemia, they're at risk of hyperperfusion. One thing that might help is teaching your patient about self-management with diuretics, also teaching them about restricting their fluid and salt intake. Now, some of that may have been called into question with the recently published FRESH-UP trial from a couple of weeks ago that didn't show any difference between strict versus liberal fluid intake in patients with heart failure. But again, patients with advanced heart failure or cardiac amyloidosis were not represented in that study. So this recommendation remains empiric. Aim for volume control with less emphasis on BUN creatinine. Expect that there will be some increases if you want to achieve euvolemia. The problem with loop diuretic like furosemide is it's very variable bioavailability that ranges between 20 to 80%. And in these patients with gut edema, gut amyloid, malnutrition, low albumin, furosemide may not perform very well. So do consider agents like furosemide or bumetanide that have higher bioavailability. There will be scenarios where sequential diuretics will be required, like a loop diuretic plus betolazone. Be mindful of the fact that that can induce very aggressive diuresis and electrolyte disturbances. I tend to use metolazone sparingly, and if I do consider it, I tend to give a test dose in the beginning. Rarely I prescribe it on a daily basis, so sometimes it could be like 2 or 3 times a week, and then adjust it to achieve the desired result. Now, if your patient has significant hypotension because of autonomic dysfunction, do consider midodrine. What about CardioMEMS, which is an implantable PA pressure monitor? We know from the pivotal trials for CardioMEMS, Champion and Monitor-HF, that a quarter of these patients, or about a third of these patients, had HFpEF. But again, we don't really know how well it works in patients with cardiac amyloid. We had a patient with variant ATTR who had CardioMEMS implanted at another center, and even though she was congested, 10 kilograms above her dry weight, the patient's PA diastolic pressures were unchanged, likely because of progressive RV failure. So there are going to be limitations with respect to the use of CardioMEMS in this particular setting. Avoid the use of calcium channel blockers, and that makes sense because of their negative inotropic effect. But with respect to digoxin, the theory is that digoxin tends to bind amyloid fibrils. This is a study from 1981, an in vitro analysis of tissue sample taken from a patient with cardiac amyloid exposed to digoxin in vitro. And when they did centrifugation to wash it out, digoxin was still detectable in the tissue and not in the control. Again, this was from a patient with AL, so we're not sure if that truly applies to patients with ATTR, but digoxin should be avoided. What about guideline-directed medical therapy, the so-called 4 pillars that we have for heart failure? The problem with randomized clinical trials for GDMT is that they have traditionally excluded patients with known amyloidosis. Even HFpEF trials have excluded them. But they did allow the inclusion of patients on the basis of LVH. So it's possible that some patients with amyloid did end up in those trials. That said, we don't have any high-quality data. What we do have is this large study from the National Amyloid Center that I shared with you earlier, basically building on their extensive experience, 22 years worth of experience of treating patients with ATTR cardiac amyloid, the vast majority being wild-type ATTR. And what they basically did is that they looked at patients who were prescribed medications like RAS inhibitors, beta blockers, MRAs, and then they compared their outcomes with propensity-matched controls. So this is the closest you can get to an RCT. And they stratified their patients according to their ejection fractions as well. So 57% of patients ended up receiving a RAS inhibitor, but just over half of them only received less than 37% of the target dose. And even with that, discontinuation rates were very high. And when they looked at their survival with respect to receiving a RAS or not receiving it, there was no difference or no impact on survival. Similarly, around 55% of patients received beta blockers, and more than half ended up receiving less than 25% of the target dose. Discontinuation rates were relatively high as well. And in the subgroup of patients with an EF of less than 40%, there was a signal for benefit with the use of beta blockers. MRAs were prescribed in about 40% of patients. The vast majority received the target dose. Discontinuation rates were extremely low. And there was an impact in the overall group with respect to a signal for benefit with respect to survival advantage of around 23%. So again, this is hypothesis generating data. It's not an RCT. You might argue that patients that are relatively healthy ended up receiving these medications, but the investigators did show that those with advanced disease are the ones that were placed on these medications. Another group did a sort of an analysis with SGLT2 inhibitors using a similar study design, using propensity matching. And what they showed is that patients who received SGLT2 inhibitors tended to do better in terms of their GFRs, NT-proBNP, and even systolic blood pressure, and even in terms of heart clinical endpoints, including all-cause mortality, cardiovascular mortality, and heart failure hospitalization. So the bottom line is that MRAs and SGLT2 inhibitors have supportive data. They're probably well tolerated. Consider the cautious use of beta blockers, probably low-dose beta blockers in patients with LV dysfunction, and exercise caution extrapolating this data to patients with light chain amyloidosis. So what about rhythm management? AFib is common in both AL and ATTR, but wherever you look at, all the data suggests that AFib is far more common in patients with prevalence anywhere between 38 to 71% in comparison to much lower prevalence in patients with AL, even though patients with AL are the ones that tend to have the more aggressive phenotype of heart failure and also a higher risk of thromboembolic events. In the National Amyloid Center study that I shared with you, about half the cohort had atrial fibrillation. The majority of these patients, again, had wild-type ATTR. So rate control with beta blocker digoxin can be considered with caution. But amiodarone is the preferred agent, pharmacologic agent, both for rate and rhythm control. This is a statement recommendation from the American Heart Association back in 2020. Do not use CHA2DS2-VASc for risk stratification for stroke prevention, just anticoagulate if AFib is detected. And that mandates periodically screening for atrial fibrillation. And it depends on what tool are you're going to use. The longer the monitoring, the higher durable patch that monitored patients for 2 weeks and AF was detected at a rate of 26%. That in AL, that yes, it does tend to develop. Patients, with AL and sinus rhythm can have clots in their left atrium, right atrium. And so there are various measures and left atrial function that are being looked at to predict who would be a candidate for anticoagulation. But we don't know if this is applicable to patients with ATTR. So for now, the recommendation for ATTR is not routine anticoagulation unless atrial fibrillation is detected. With respect to device therapy, the utility of pacemakers is around 9%. For advanced heart block, and there's debate on whether to use cardiac resynchronization therapy up front. I would argue that should be the case. With respect to the use of ICDs, it's still fairly low. In various studies that have looked at ICD implantation in patients with ATTR have basically shown a low rate of appropriate shocks. Patients with AL do tend to have a higher frequency of appropriate shocks, but patients with ATTR don't. So the current recommendation is to use the conventional recommendation, EF less than 35% or less than 30% as the threshold for implanting an ICD for primary prevention if the expected survival is greater than 1 year. So in terms of follow-up, continue supportive measures and assess disease progression. You can use the KCCQ, NYHA class, the 6-minute walk test, in addition to biomarkers and echo to assess if your patient is progressing. If that's the case, you have to address the question of what to do with the disease-modifying therapy. That's going to be beyond the scope of my discussion here. But the other aspect that comes up is whether advanced heart failure treatment options should be employed. And this is data regarding cardiac transplantation at a National Amyloid Center over a period of 3 decades. Only 14 patients underwent cardiac transplantation. The vast majority of them had wild-type ATTR, and their survival was very acceptable. 5-year survival was 90%, and it was much better than patients who did not undergo heart transplantation. Sometimes transplant is not an option. So what about LVAD? Very limited experience. It can be deployed in expert hands, but important considerations are the small LV size, the thick walls, the risk of suction events. So a lot of times, core resections are necessary to accommodate the LVAD. So I'm going to conclude here with a couple of statements. So basically, supportive care for heart failure plays a crucial role in managing heart failure in ATTR-CM. Diuretics, MRA, and SGLT2 inhibitors could be considered a mainstay of management. Areas of uncertainty include anticoagulation and sinus rhythm and the role of ICD for primary prevention. And as disease-modifying therapies improve outcomes, the role of conventional treatments will need to be revisited. Thank you very much for your attention.
Fantastic job. Thank you so much, Ammar, for this overview and for putting us back on time. Last but not least, in this first session, it gives me a great pleasure to introduce Professor Stefano Perlini, who requires no introduction. He is from the Pavia Amyloidosis Center, and he will be discussing recent advances in disease-modifying therapies for ATTR cardiomyopathy. Dr. Perlini?
Yeah. First of all, thank you very much for the very kind invitation. It's an honor for me, and I can really witness how in your area the knowledge and awareness have been growing in the last recent years, and that's really a wonderful thing, and I wish to congratulate to everybody in the Gulf area, in Saudi, in Jordan, for having, for having filled the gap of diagnosis and treatment. My duty is to try to see whether there are disease-modifying drugs. If you think for a moment at the story of the disease, you have an amyloid precursor or several proteins that will become misfolded and precipitate as fibrils. So at least in theory, to try to change this disease, you can either shut down the production or increase the stability of the molecules, or try to look and to catch for the oligomers, or even to try to take away the deposits from the tissue itself. When we can try to see what is the situation in transthyretin disease, that is one of the many different types of systemic amyloidosis that we all know, we have to get a little bit on the history. This is the history of the heart. You can see that there is also an history in the NERA for amyloid. And I wish to remind myself and everybody here that 10 years ago, that was not centuries ago, it was only 10 years ago, the majority of the people and in the cardiology arena were thinking that ATTR was untreatable, meaning that we had only supportive therapy. We didn't have at all any disease-modifying drug. And that was very depressing for anybody who was diagnosing and trying to follow up these patients. What is the situation now? In this very recent review by Marianna Fontana, we can gather the different data we have on trials in this disease. Just to sum up them, we have stabilizers, we have gene silencers, we have gene editors, and we have depleters. This is the research, and this is something that will change the scenario in the next few years. But up to now, the only approved intervention for this disease is to use to use stabilizers. And this is the situation today in my country, in many of your countries. Maybe tomorrow or in a month, the situation will change as long as these data will become something that will be available for our patient. So up to now, this is the situation. First of all, this is the position statement by the European Society of Cardiology stating that a stabilizer is a perfect option with many patients with ATTR, either wild type or variant. But the point I want to share with you here very clearly, the situation is that now cardiac amyloid is no longer untreatable. There is treatment for it, and it's very important to understand that this is really a disease-modifying treatment. I'm sure you are very familiar with this trial, the ATTR trial, that was so important in the natural history of the disease. Just to sum up, 441 patients, 3/4 of them with wild type, 1/4 with mutated forms, and these were the main results. 30% reduction in mortality. That there is a figure that we never saw before in cardiac trials. So basically 1 out of 3 is the reduction of mortality, meaning that there is a possibility of survival. This is really a milestone for the disease. And last but not least, we have to remember that the number needed to treat to achieve the result is 7.5, meaning that this number is much lower than the number needed to treat in many other either therapies or intervention we currently use in our cardiac patient. This study was also very important, not only because it was underscoring a mortality advantage, but also because the quality of life was affected. Even at 6 months, there is an improvement in either the 6-minute walking test or the Kansas questionnaire as proxies of morbidity. And also on the top of it, survival was also associated with the reduction need to go to the hospital and to admit these patients. As with many studies, the long-term extension that was just giving to the patient initially randomized to placebo the opportunity of receive the active treatment confirmed these results over the long term. Last but not least, safety was not an issue because the side effect of this stabilizer is very, very benign. So we don't have issue related to side effects of this treatment. Some extra post-hoc studies were focused on either the more severe heart failure, New York Heart Association class 3, or I will see in a minute on elderly patients. First of all, these are post-hoc, so they are not rocket science. They are just data helping us in thinking about the disease. But having said that, it's clear that also New York Heart Association class 3 patient, the most severe, can have a benefit. Obviously, a lower benefit because they start from a worst startup point, but still this is present. This is something we have to think, even if we are not allowed, at least in my country, to treat patients with class 3. What about the octogenarians? That means the elderly. Also, the elderly did have a signal of advantage. And this signal was confirmed by our colleague in Belgium with this very recent, very nice paper. They took a cohort of 710 elderly patients, showing that in this patient, provided that the frailty was not too advanced, there was a possibility of having an advantage from this drug. So age is not a ceiling, provided you use together with age, with the ID chart of your patient, also a frailty indication of them. Because obviously, in this age class, futility of any treatment should be taken into consideration. But having said that, I'm sure that New York Clinic, you see patients who are very fit even at that age. And so the signal of a possibility of improving morbidity and mortality in this patient should be taken into account. This is from the trials. What about the real world? Because we normally work in the real world, not in the world of trials. So one question is, does this apply to the real world patient? First of all, 1 year after the trial, that was 2019, in the Italian cohort, we tried to assess this, to see, look, are the patients that were selected for the trial similar to the patient we normally see in our clinic? And this was the case. Actually, the patient we saw in the real world were at most similar or a little bit worse than the patient who were randomized into the trial, telling us that even at the time when it was not possible to prescribe the drug, at least in my country, because this was possible only a year later, it was very important to keep in mind that that trial was telling us something that is applicable to the real world. In the real world, many studies came out in the last years, and I am sure that this year many others will come. Obviously, the message in the real world is the following. Even if you treat your patient in the clinic, you will have the same advantage that you are seeing in the trial. And this is very important. What are the barriers to treatment in this study by Hussein? The barriers are many. One that is very important, obviously, is the price or the severity of heart failure, but also the organization of our hospital in obtaining the drug from the pharmacy to the wards or to the clinic. Another study that was, in my opinion, very important, 1,300 patients, of whom 500 were on treatment. This study not only confirmed the mortality advantage, but also in a propensity score matching was also showing that the number of hospitalization with all the cost that is involved, not only in terms of economics, but also in terms of family relationship, work capabilities, and capability to have a normal life is concerned. So also here we have a signal that this drug is available and the advantages have to be translated into the real world. What about the safety of the drug? One measure of safety for our patient is the following. If a patient is affected by side effects of any drugs, we know very well that the patient will not persist on treatment. Maybe they will tell us in the clinic that they skipped some drugs, some option of the drug, but in the reality, they will not stay on adherence. Two studies, one is this one from Japan, and the second one is this one from Germany, are showing that this is not the case, telling us that after 1 year, the majority of patients will still be on treatment. This is because, on the one hand, we convince them of the advantage. On the other hand, they didn't experience any side effects that was enough to skip drug and to be less adherent to therapy. So in one word, I would say that the data we have is that indeed, in the real world, this is one possibility. And this is for the stabilizer, what we can use now in my as well as in your countries. In general, we have to keep in mind that this disease is one example of precision medicine in cardiology. Why am I saying this? First of all, because the many studies that were undergoing and took advantage of many research and publication were able to elucidate at least part of the underlying disease mechanism. Imaging was very important. As pointed out earlier on, we are lucky in this disease because once we have the suspicion, several imaging tools can help us in reinforce the suspicion and in getting to the diagnosis. Echo, nuclear magnetic resonance, or bone scintigraphy, as you very well know. Obviously, it's very important that you exclude AL, as probably said by my colleagues minutes ago. We also have many data on epidemiology that are telling us how important is the disease in some special areas: heart failure, aortic stenosis, unexplained hypertrophy, hypertrophic cardiomyopathy, or many other orthopedic or neurological conditions together with a strange heart that we can image. This led to several therapies. Many of them are under study. Very soon, we will have the possibility and the opportunity of using not only stabilizer, but also other ways of interacting with the disease. And I am sure that in the next few years, we will see many other new things that are very exciting for our patients. Think for a moment, 10 years ago, no treatment. Now we have several lines of treatment. It looks like that 10 years were almost just changing completely the scenario of this disease. Many pending questions are still open. It's important that once we know something about the disease, we have to be humble enough to understand that there are several other options to think, not only as far as diagnosis or mechanism are concerned, but also to the best proper use of disease modifying and the supportive therapy. Having said this, let's consider that if this is one of the patients we can see, you know that heart failure is just a roller coaster. They enter the hospital, they go out and back and forth. We have to do the following. In our patient, there is an ideal therapeutical window. We have to do the best we can in order to anticipate the diagnosis and the suspicion. And I am sure that meetings like the one that was proposed tonight can help us in understanding how important it is to suspect, to use the proper diagnosis for this patient, and to refer the patient to the centers who are taking care of how to select therapy and how to treat them. And in the Gulf area, in Saudi, many centers are growing on this respect, and I am sure that we will do an optimal job for this patient. Thank you very much indeed for your attention, and I will be very open to any question. Thanks a lot. Shukran, I have to say.
Thank you so much, Professor Perlini. And we'd like to thank all the speakers in the first session. A lot of wisdom has been exchanged. We're running behind, but I would like to kind of take a few questions from the chat. And let me start from the last speaker. Dr. Perlini, you've talked about the role of stabilizers, predominantly tafamidis. Now, we're all aware that there are additional medications that have been FDA approved, granted that they are not available in our region. So we have acoramidis, which is another stabilizer that has been approved. You have vutrisiran as a TTR silencer that's also been approved recently. And there's another eplontersen is underway in the clinical trial is still underway. So my question to you, do you, and building on the precision medicine concept, how do you see these medications being implemented and used in patients with ATTR cardiomyopathy? Is it going to be one medicine for everybody? Is it going to be silencer for certain phenotypes, stabilizer for others, combination for some? What are your thoughts if we were to look 5 to 7 years down the road?
Well, thank you. That's an excellent point and an excellent question that we have to face. First of all, let me say that we don't have head-to-head comparisons. So this is something that should be clear. And to compare patients enrolled in the very recent trial to the patients enrolled in ATTR can be a little bit misleading just because the diagnosis has been advanced so much. Having said that, I am very curious about the possibility of having different ways of touching upon the disease. Let's say silencers on the one hand and stabilizers on the other. Ideally, a combination of this approach can be very tempting, although the cost is really an issue. But the mechanisms are completely different and probably can change. For sure, a stabilizer should be very helpful whenever the disease is already diagnosed, and all the advantages we have in mortality, morbidity, reduction in toxicity, and so on are very reassuring. A silencer can be very tempting in the carriers of the mutation, in whom you want to have a start point in which to try to switch down the production in order to improve the prognosis. This is something that we will know very soon, because when we will have more data, and many data are in the pipelines, we will know how to try to tailor therapy. But let's say the main point is that now it's treatable. This was not possible 10 years ago. I had the frustration of having patients in home, diagnosis was made, and no option was possible to offer. So we are very lucky nowadays to have many bullets to shoot against this disease.
We are indeed. We are. Thank you for that answer. I would like to invite my colleagues to join, Dr. Ranzo, Dr. Ammar, Dr. Khalid, for this quick Q&A. A question in the chat came for Dr. Khalid, and I will paraphrase. Do you do all testing modalities for all patients with suspected ATTR cardiomyopathy, or do you have a specific sequence? So if you're suspecting ATTR, do you have to perform cardiac MRI and PYP?
So regarding this question, Dr. Firas, my advice for anyone, use whatever is available in your hospital or institution. For sure, if I will choose one, I will choose the PYP scan or nuclear scan, in addition to blood work. But if you are working in a tertiary hospital, I would prefer to do everything you have, because for sure it's like every test will complement the other test. So for sure, I will do echo as first line screening. And just to confirm the diagnosis, I will do the BOIB scan and blood test. If you have MRI, this is great. And yes, I will advise to do.
Excellent. So if you're suspecting wild type ATTR and you've ruled out gammopathy and you have uptake on radionuclide imaging, in your opinion, what does cardiac MRI add in terms of the diagnosis in that case?
So the MRI, first of all, it will help to confirm the diagnosis from imaging perspective. Second thing, it can help you to add some information regarding the prognosis and to have a baseline. So if you are considering like starting treatment for this patient and you want to follow up the patient, for example, after 1 year or 2 years, you can follow up certain parameters like the T1 mapping, the extracellular volume, the LV mass. There is a lot of information you can do. Also, for example, if the BOIB scan came negative and you want to check like other differential diagnosis, for sure the MRI is a great tool to differentiate between different cardiomyopathies. So it's like a great diagnostic tools in the hands of the cardiologist to have this complete assessment and assessment, I mean, for the patient.
I totally agree with you. So perhaps not much in terms of confirming diagnosis right now. If you have unequivocal myocardial uptake on PYP, but perhaps something that you can use to prognosticate or to follow response to treatment.
Exactly.
A question that came for Dr. Ammar. The classic teaching is that these patients don't tolerate RAS modulators and don't tolerate beta blockers. And in early position statements, there was a recommendation that these medicines should be discontinued because, and that's been associated or linked to improvement quality of life. Has that been your approach, that you routinely discontinue these medicines, or have you taken a more selective approach? Ammar, can you hear us? Okay, maybe we've lost Ammar. Ramzi, do you want to weigh in or on that? Do you routinely withhold RAS modulators and beta blockers on all ATTR patients, or you have a selective approach?
No, we don't. For us, and for obvious reasons, these patients may depend on these medications for at least good, an acceptable quality of life. So you cannot just withdraw medication.
I mean, so I will share with you an anecdote where a patient was diagnosed with ATTR.
Do you want me to continue?
Why don't you briefly finish your thought, and then we'll go back to Ammar if he remains with us.
So I say you cannot just stop medications because now you have a new diagnosis of ATTR amyloidosis. What we typically do is, we fully assess the patient's condition, the hemodynamics, the blood pressure, the pulse, how the patient is feeling, the condition with the fluid status of the patient, the kidney functions. And then we gradually change the medications. We gradually, shift between different medications or change the doses up or down depending on the condition of the patient. As Ammar said, none of these medications is absolutely contraindicated in patients with ATTR amyloidosis, but you have to be very careful with certain medications because of their poor tolerance to, diuretics, their poor tolerance to negative inotropic agents, their poor tolerance to medications that produce reduction in preload or reduction in blood pressure. So it's a matter of being more cautious than, putting red lines, saying that I can use this medication and I cannot use this medication. This is not how it plays. It plays, but you have to be very careful. You have to understand the pathophysiology of the disease, and you have to modify your medication approach accordingly.
Fair enough. Ammar, you were about to say something and we lost you for a second.
Yeah, sorry about that. Yeah, there's some issue with the connection. So, I did have a couple of patients that were started already on the 4 therapies: ARNI, beta blocker, SGLT2 inhibitor, and an MRA. And so I kept the SGLT2 inhibitor, I kept the MRA. I had to go up and escalate the diuretic dose, but they were not feeling well because of hypotension. So initially I downgraded them from an ARNI to an ACE inhibitor. The ejection fraction was impaired, it was around 40-45%. And as their disease progressed, I had to take them off the RASI completely, and then even down titrate the beta blockers. So that was an indication of disease progression in my mind. But yes, I mean, if it's someone who's tolerating all the therapies, I don't think that happens very often. You can potentially keep them on it, but frequent follow-up is necessary to make that adjustment.
Fantastic. Dr. Perlini, briefly, has that been your approach as well, or you have a different approach?
No, I fully agree. We don't have to forget that these patients do need and do have very likely an advantage from the pillars of our treatment. The only attention I try to have is that I have to be very careful that in any patient you have to tailor therapy, in this patient even more, just because they are less tolerant to some standard HF therapies. But this doesn't mean that they are contraindication. It just means that they have to be more careful.
Very, very, very sage advice from all of the speakers. I will close this with a question to Ramzi. I was particularly fascinated by the data you presented on the breakdown of the diagnosis, the breakdown of patients with amyloidosis in your practice. Do you think that's a matter of referral patterns that are unique to your center, where you've seen predominantly AL and variant ATTR and a substantially smaller proportion of wild type? Because I can tell you, in our experience, wild type is the most common and variant is the least common. Do you think that reflects true prevalence in your region, or just a referral pattern?
I guess it is because the wild type ATTR usually involves older populations. The hereditary type usually involves people in their maybe late 40s, 50s, and 60s. So these are young, active people, and when you compare those people to the population of patients with the wild type ATTR amyloidosis, who are typically patients in their 70s and 80s. I think the younger people are more interested in, trying to find out what they have and trying to seek medical advice and get treated. They're interested in that, and their family members are also interested in that. So I think the thing is not that because we have more prevalence of the hereditary type of ATTR amyloidosis, just because patients being younger, patients with the hereditary type, they are more active in seeking medical advice, and that's why we see more of them. Patients who are older, they usually accept what they have. Their family members also accept what they have. Most of their symptoms will be attributed to, being old, or a multiplicity of other conditions like, the usual heart failure, maybe hypertension, maybe lack of, physical fitness, smoking, things like that. So people accept that these old persons are diseased, and they don't really want to be active in seeking different therapeutic options for them. And you can say that a bias, but it's not from us. It's a bias. It's a kind of who comes to an amyloidosis center, who doesn't.
We're not gonna blame you for that. We're not gonna hold that against you. I want to be respectful of everybody's time. There are a lot of good questions that are in the chat box. We can have this conversation for forever. But I would like to close the first session and thank Dr. Ramzi, Dr. Khalid, and Dr. Ammar for your really valuable insight that you've provided. Thank you so much. And we'll move on to the next session. And as we transition to the next session, I would like to acknowledge, first, thank everybody who joined this meeting, and acknowledge our sponsors whose generous support made this event possible. And I would like to introduce to ask Dr. Perlini to join me in introducing the next speakers. In the next session is titled Case-Based Discussion on Commonly Encountered Dilemmas in Managing Patients with ATTR Cardiomyopathy. We have two presentations. The first one is going to be by my friend and colleague, Dr. Imad Hakimi, who is an interventional cardiologist with special expertise in structural heart interventions. Imad will discuss patients with concomitant aortic stenosis and ATTR cardiomyopathy. What's next, TAVR or SAVR? So this is going to be a case-based discussion. Imad, take it away.
Good evening, everyone. Can you hear me?
We hear you. Okay, Imad.
Okay. Well, it's a pleasure to join you in this lovely evening and such a beautiful discussion. I'm really learning a lot. Let me share my screen with you all. I promise I'll get us back on track on time. Here we go. Can you guys see my screen?
Sure.
Okay, so as Dr. Firas alluded, I'll be discussing concomitant AS and cardiac amyloid. It's a problem that's becoming recognized more and more, and there's a lot of collaboration happening between valve clinics and amyloid clinics to try to capture those patients and see how early recognition might impact outcomes. My name is Imad Hakimi. I'm an interventional cardiologist at Cleveland Clinic. Moving on. I have no disclosures relevant to this talk. In general, aortic stenosis is a very common condition as we get older, and also cardiac amyloid is common as we get older. Based on the data that I was able to pull, up to 25% of people who are 85 and older, when they do autopsies, they actually find some deposits. Does that translate to clinical symptoms or not? Depends where are in the spectrum of the disease. So they are bound to coexist together. And there's some interaction between both of them. Some theories out there that the afterload can impact how much deposition happens, and how would impact the progression of the amyloid. On the same side, how much the deposits actually impact the valve structure itself and how it impacts the progression of the aortic stenosis. So there's an important interplay between both of these pathologies. Hence, there's a lot of emphasis and interest in trying to find the common ground between both these conditions. It depends what cohort you look at, but the coexistence between both can vary between 5 to 15%. If you're someone who mostly treat younger patients with AS, it's likely that you're not going to have the higher side of the prevalence. If you're someone who's most of your cohort are on the older side, who come to you with aortic stenosis, you actually more likely to have the higher prevalence in that spectrum there. So why is it important? Well, sometimes it can cause having concomitant cardiac amyloid with AS can lead you the wrong pathway. Instead of focusing on what's the real problem is, you can go into a realm of misdiagnosis, especially if you have a moderate AS, that in a case where you did not diagnose cardiac amyloid, you have truly a moderate AS presenting as low flow, low gradient, or paradoxical. You have low gradients, but you focus on the AS, but you miss the actual true problem, which is amyloid. And now we have all those new therapies that have been clearly identified by our esteemed panelists. So it is important to diagnose amyloid because it will have impact on therapy. And amyloid itself is a disease modifier for AS, and the same goes for AS. It could be a disease modifier for cardiac amyloid. That's why it is important to make that separation. It's actually it has direct impact on the outcomes of patients. I'll start with my representative case, 76-year-old guy with a history of HFpEF, AFib, pulmonary hypertension, CKD, GFR between 15 to 30. baseline dementia, and a lot of comorbidities, as we see. He presents multiple times to the hospital with acutely decompensated heart failure, NYHA class 3 at home between the episodes of heart failure decompensation, which he gets admitted to the hospital. BNP 27,000, chronically elevated troponin, usually referenced the fact that he has CKD, and as we see on the echo LVH, chronic anemia. This is his EKG, low voltage in the limb leads, not poor R wave progression in the precordial leads. This is his echo, thick ventricles, even the RV wall is thick, as we can see. We see the severely restricted mobility of the aortic valve. The mean gradient is 33, so it's not the usual. We don't have a very high gradient, so the diagnosis of AS wasn't that clear. You can see the clearly restrictive pattern of diastolic function on his mitral inflows. He did have apical sparing, clear apical sparing on the longitudinal strain, and his mitral septal excursion was also severely reduced. So there were clear echocardiographic findings to support the suspicion of this patient has aortic stenosis plus cardiac amyloid. We did a TEE just to understand more the degree of aortic stenosis and help us also do some measurements for the procedural planning. He does have thickening in the mitral leaflet. He did have a concomitant +2 AI and clearly thickened leaflets in the aortic valve and clearly restricted mobility of the leaflets. So the findings were all supportive of hemodynamically significant AS. We did an angiogram. He has an RCA-CTO and a critical lesion in the proximal LAD. So this poor guy had multiple things going on, cardiac at least, to explain why he might go into heart failure. But the echocardiographic findings were extremely supportive of underlying cardiomyopathy. LAD was fixed in the same setting. When we do the CT scan, we look for the aortic valve calcium score because he did have low flow paradoxical AS. So we want to make sure that we understand more the calcium burden. As you see in those videos, his calcium score was 1200, which is not usually for men. You want 2000 and more, but it's something we appreciate here more, at least in this region, that calcium scores, the studies that have been done, it mostly reflects different populations, mostly Western populations. Here, at least in the area here where I practice, we see more fibrotic, less calcific AS patients. So as we see, but there was definitely enough calcium to suggest that this AS is important. Based on everything I just said, the next logical step based on the diagnostic workup that was already presented by earlier talks, we did a PYP scan, which was positive and highly supportive of the patient having cardiac amyloid. That brings me to this few points I want to focus on is that there's a diagnostic challenge. Most of the time, you will go for the things you see in front of you. So we all see that the AS was there, and that makes you need to have an active thought process about finding those patients who have also concomitant cardiac amyloid. So you have to have the clinical suspicion, and that's hence those meetings we attend and talking to our colleagues who are experts in this field. This way we keep this topic at the back of our brain ready, like in the RAM memory, ready to jump when we see those red flags that we can see here. There are some clinical red flags. They've already been mentioned thoroughly. EKG red flags, echocardiographic red flags. In this patient, I would say what really drove the attention and the eyes is mostly because his echo was very suggestive of cardiac amyloid. The routine workup includes the basic stuffs, obviously the serum and the urine monoclonal chain check and the cardiac MRI and the PYP scan. This is something already been discussed. But I do want to mention that in echo, most of the patients who have AS and concomitant cardiac amyloid, most of them have the low flow, low gradient AS or the paradoxical AS. a majority. Obviously, you can still come across patients who have the classical definition of AS with a mean grade of more than 40 and a valve area less than 1, but most of them actually fit in the criteria where they have low flow, low gradient with mildly reduced EF or preserved EF, but low stroke index. So meaning they have paradoxical AS. This has been already mentioned before. Biopsy, obviously, in select cases, you need to where you get the congruent stain, and that can be helpful. This is a nice overview of the workup where we start with aortic stenosis, because usually it's the most obvious pathology that can explain clinical syndrome. But if you find one of those red flags, then the next step is, as my colleagues already explained that thoroughly, is to go through the process of trying to find out if they actually have concomitant cardiac amyloid. How to manage, obviously, medical management for the heart failure symptoms and already those classical teachings of stopping beta blockers and ACE and ARBs, and Dr. Firas already asked a question about that. That depends on case by case. They are sensitive to diuretics, especially because of the AS. Usually AS patients they need the volume to generate the output. So if you have on top of it amyloid, they are super sensitive to diuretics. Usually patients with AS who are short of breath, the usual practice, not necessarily wrong, is give them a low dose of diuretics. But usually they feel miserable. Usually their blood pressure becomes soft. This is something that we can see clinically. There's targeted therapies for L or ATTR, including even heart and liver transplant. If it's hereditary, that's when this can be considered. But my focus will be now on the actual what to do with the aortic stenosis. Both those pathways go in parallel. But they do impact the decision making, especially when we start talking about procedures. In general, the data behind which has the upper hand, surgical versus transcatheter aortic valve replacement. The data is not like randomized high-level data where you can really say with confidence which has the upper hand or not, but there's a general theme that's been shown multiple times across different studies, including meta-analyses and propensity score matched even methods, that surgical AVR have more peri-procedural complications, including signal of higher mortality. Obviously, there's more length of stay and the complications, including bleeding. So TAVR has the upper hand when it comes to that. Now, when you want to compare TAVR in patients with and without cardiac amyloids, what's noticeable actually is if you're doing a TAVR on someone with cardiac amyloid, they do have higher risk of pacemaker placement because of the conduction system involvement with the cardiac amyloid. Usually, when we do TAVRs, we tell patients the risk of pacemaker in busy centers, experienced hands is around 5%, I would say. Now, when the studies showed when you do TAVR on those patients, it can go up to 15%. So clearly, there's higher risk of requiring a permanent pacemaker, and on top of it, there's a higher risk of actually post-procedural strokes. What exactly is the reason for that? There's no clear explanation. But when we talk to patients, we tell them that the risk of stroke is less than 3%. Some trials showed that risk of stroke in TAVR patients with cardiac amyloids post-procedurally can go up to 6%. So there have some people say a more like a broad thrombotic state that you have to take that into consideration when you discuss that with patients. So overall, the preference is toward transcatheter therapy over surgical. Obviously, the things that will make us not do TAVI is the anatomy. If the patient's anatomy is not suitable for TAVR, then the only option becomes surgery, and the discussion becomes, okay, tell me what the EF is, if is the longitudinal strain severely reduced or not? Do they have severe pulmonary hypertension? What's the RV condition? Because if those things are not doing well, then even surgery might become not an option. Back to our patient, we did, the workup was done as an inpatient, so MDT discussion, we evaluated everything, and the decision was to assess the anatomy. and his vascular access was fine, and his anatomy was suitable for actually to proceed with TAVR, and he ended up getting a Navidor 26, which was uncomplicated. In conclusion, I want to just touch something on a clinical, I feel it in my clinical practice, is that yes, we understand that there's a coexistence now. This is something we recognize more and more, and makes a lot of sense to actually capture those patients who do have concomitant cardiac amyloid. Early diagnosis does impact outcomes, because as I'm learning more and more, you know, the stabilizers and the silencers, it's important to catch those patients early. But additional testing can be overwhelming. I find it really hard to start talking to my patient when I discuss with them, I'm going to do a CT scan and I'm going to do an angiogram, I'm going to put you through a TAVR procedure. And on top of it, I start another big thing about, I'm going to do a PYP scan, I'm going to check for light chains, I'm going to consider you for a biopsy if needed. It becomes really overwhelming. And that's why I feel, and that's something I feel when I have those discussions with my patient in clinic. I think it's important. That's why we need cardiac amyloid programs. We need experts to help us and walk the patient through why it's important to diagnose this condition and how it actually impacts their outcomes. We need more studies, obviously. Should we intervene on moderate AS in patients with confirmed cardiac amyloidosis if it actually impacts the natural history of amyloid? What's the role of disease-modifying therapy after you put the TAVR? Does it impact the outcomes? And there are some new randomized trials in track, and hopefully that will shed some light on this. These are my references, and thank you for your attention.
Thank you so much, Ahmad. That was a very detailed overview. I really appreciate the diligence there. A couple of quick points. Early on, before we had effective treatment, the diagnosis of a concurrent disease, there was discussion about the futility of TAVR in patients with concurrent disease. That's no longer the case, correct? I just want to make sure that the audience gets the correct message.
Right. Your question was about futility, correct, Firas?
Correct. Futility of TAVR in patients with concurrent ATTR and AS.
You use the same markers about futility. Futility, you take it if the patient, not necessarily because you pin the diagnosis on him of cardiac amyloidosis, but because of everything else. So if the patient has severe dementias, the patient has high-level frailty, you take those things into consideration, not specifically because he has cardiac amyloid.
Right.
So it's not fair to take that TAVR therapy out of the equation just because they have amyloid. That's probably more applicable to surgery, like, because yes, if the patient you're considering for surgical AVR, then yes, your criteria for surgery will be much higher, and you'll have more barriers to provide that therapy. Yeah.
And I also feel your pain. Do we screen everybody who comes to with severe AS? Do we screen everybody for ATTR? The Cleveland Clinic experience, they looked at everybody with severe AS and
65.
age 70 and up.
70
and up, and their yield was 5%. So that means there is 1 positive PYP and 19 negative PYPs. That is not a high yield. And I think a more nuanced approach would be more appropriate. Do you agree?
The caveat to that, a place like Ohio, they do 600 TAVRs a year. So so with volume, you capture a lot of patients. So it's always the balance between how much is too much. Like, it would be nice to be very specific, but then you might probably going to lose some sensitivity. I know you know that more than I do. To me, it's about I really like the red flag system, because I'm a simple guy. If I listen, I can, any clinical findings of neuropathy, immediately I have a red flag. I look at the echo, nothing, walls are thick, that's another red flag. I like the simple stuff, but I leave it to you experts to tell me exactly how can we fine-tune those tests. But they can become overwhelming.
I agree.
Yeah.
This is an amazing discussion. Just for the sake of time, I'm going to turn it over to Dr. Perlini. Ahmad, thank you so much. There's a lot of knowledge you've shared with us. Dr. Ferlini, we have another case before the end of the hour.
Thank you very much indeed. I agree with what have been said up to now. It's really my pleasure to introduce Dr. Juwairia Alali. I hope I pronounce it correctly. She is not only a consultant cardiology in Dubai at Rashid Hospital, but she is also the president of the Emirates Cardiac Society. So it's really a pleasure to introduce her. And I am just noticing that we have more than 200 participants. That is, in my opinion, a signal of how we need your input. Please, Dr. Juwaira, your case that will be, from the title, very exciting. Thanks.
Thank you so much for the introduction. And yeah, it's great. Like we have lots of audience coming in, and we also have lots of questions in the chat. So that just tells you how people are interested in this topic. So my talk is going to be very light and easy. It's a diagnostic problem that we face. Sometimes we think the patient has ATTR cardiomyopathy, but the PYP scan comes out negative. And what do we do in this situation? So I'm just going to show a case. I'm not going to show a lot of data. And I would like the other speakers to weigh in as well. Do they think this is a high suspicion case? Should I do something else or not? So this lady is 76 years old. She's diabetic, hypertensive with paroxysmal atrial fibrillation. She's known to have ischemic heart disease with multiple PCIs done. Last one was in 2018. She has chronic kidney disease, stage 4, with an eGFR of around 20 ml per minute. And she's diagnosed with hypertrophic non-obstructive cardiomyopathy. She had 9 admissions with heart failure with preserved ejection fraction between the years of 2022 and 2024. And when I saw her, so this was in last October in 2024, her blood pressure was 158/78, her heart rate was 67, she had no lower lymphedema, and her chest was clear. So this was her medication. So she was on apixaban 2.5 twice per day. She was on bisoprolol 2.5. She was on empagliflozin. She was on a low dose of furosemide. And she was on hydralazine. And we see that very frequently. And diabetic with CKD, for some reason, people are always afraid of using ARNI. And we see them on hydralazine for the management of hypertension. She was also on insulin. She was on linagliptin for her diabetes management. She was on ranolazine because I assume at one point she was complaining of chest pains. And she was on rosuvastatin 20. Her anti-proBNP was 1,199, but her troponin was also elevated, chronically elevated. It was at around 65 high sensitivity troponin. And her hemoglobin A1C was uncontrolled, so it was 9. Her sodium was normal and her potassium was normal, and about her GFR. So this was her ECG. So she has paroxysmal atrial fibrillation. So I was lucky to have an ECG and sinus rhythm. And if you see, I mean, she has a long PR interval. She has an incomplete right bundle branch block. And for someone who's labeled hypertrophic cardiomyopathy, you don't see like very striking LVH over here. And this was her echo. So if you see significantly thickened septum, and it's a little bit speckled as well. This is the short acting, and you see complete obliteration of the LV with systole. There's no pericardial effusion. She had thickened valves, and her apical images were not that good. So we couldn't do strain because her apical images were not great. This is her diastolic function. So you see that she has significant diastolic dysfunction, and her tissue Doppler was significantly abnormal. So at that point, I thought there is a good suspicion that she would have cardiac amyloidosis. She has HFpEF, she has LVH, she has some conduction abnormality on ECG. And so I sent her for a PYP scan. And this PYP scan was reported as negative for ATTR cardiomyopathy. So, I mean, maybe the panel can weigh in right now before I go further. Do you think this is a high suspicion case that I need to do something about this? Or maybe I was just too enthusiastic for doing the test and let's just leave it as is?
You're always enthusiastic, Dr. Juwairia, but I agree with you. It has a lot of, smoking gun and a lot of red flags. Impaired diastolic function, unexplained LVH, biomarker elevation, the restrictive pattern. I think suspecting amyloid is totally reasonable in this case.
So
Dr.
should I do
Perlini?
something? Yeah, Dr. Perlini.
Oh, yeah. I would go further for the diagnostic follow-up, because we have to keep in mind that in some patients, for a reason we still don't know, bone scintigraphy can be negative or falsely negative. So it's very important just to keep on the red flags, on the clinical and biomarker red flag.
You know, just a couple of points, Dr. Juwaria. On when PYP is negative in a highly suspicious case, what comes to mind? Number one, was the test done incorrectly? The tagging of the tracer or something that just, you know, the tracer was not administered appropriately. That is probably not the case in your patient, because you can see on the screen there is uptake in the sternum, there is uptake in the ribs. So the tracer tags the bone. So that is not the case. Number two, was imaging performed, you know, with significant delay? We had a patient who had to be sent to the ER. She had syncope, and then she returned several hours later. You know, the half-life for technetium is 6 hours, but you know, you want to make sure that the patient is not imaged with a significant delay. There are, as Dr. Perlini said, there are certain genetic abnormalities that yield a negative PYP. Remember, we don't still understand what does PYP bind to in patients with ATTR. So I agree that this should not be the last step. More workup was warranted.
So I'll continue the story. So of course, we did the biochemical testing. So she had an increased light chain kappa and light chain lambda, but the ratio was normal, and she had no cardiomyopathy. So we took AL out of the equation. So, I mean, I adjusted her therapy, reduced the hydralazine, introduced ARNI because she needs some sort of proper HFpEF management plus renal protection and someone who's diabetic. But then she got admitted with a stroke. And she had atrial flutter and then fibrillation during the admission of a stroke. And we did the transesophageal echo. So this is her transesophageal echo. You see significant smoke in the left atrium. And you look at the appendage, and it's very highly suspicious of a left atrial appendage clot. I mean, it almost looks like a jelly type. And just to confirm that, we did echo contrast injection, and you can see the clot very clearly. So very clearly, there is a filling defect within the left atrial appendage. So she has a left atrial appendage clot. So that also adds to the idea that this is pointing toward amyloidosis, you know, because these patients tend to have thrombosis very easily. So, I mean, why would you have a false negative PYP scan? I mean, you just alluded to that. Well, it's possible in early disease, but this patient is not early disease. She's clearly advanced disease. And there are some pathognomonic TTR mutations that can have a negative PYP scan. So it is reported to be less sensitive in hereditary ATTR cardiomyopathy. So the guidelines tell us that if the suspicion is very high and you have a negative PYP scan, you need to do a myocardial biopsy. Now, the limitation for that is we're talking about elderly patients who tend to not want to go for invasive therapy. So, I mean, ideally, we should go for myocardial biopsy, but most patients actually refuse to do that. Sometimes you can consider other imaging to help you guide the suspicion, like CMR. But in this case, you know, she has renal impairment. We cannot give her gadolinium, so this is problematic. Or you might consider repeating the PYP in case this is an early diagnosis. But I don't think that's the case for her. Now, the one extra piece of information that I didn't put in the presentation because it happened today. So after that clot, she came in, we switched her NOAC to a different type because we thought maybe there was an issue with compliance. She was in apexaban twice a day, and she was an elderly lady who administers her medication by herself. So we switched her to a once a day rivaroxaban renal dose. And today she came in for the repeat TEE to check that the clot is gone. And honestly, I should have showed you the images, but I couldn't put them. The amount of spontaneous echo contrast in the left atrium was so huge that it is only equivalent to what you see in rheumatic mitral stenosis, very tight valve. So I think this lady has ATTR. So right now, like, I'm even more convinced that she needs to go for myocardial biopsy, because the amount of contrast is unexplainable. And I think that should go into some calculation in terms of suspicion of ATTR cardiomyopathy. So, I mean, it's a light case. I think it's a nice closure for this meeting. Yeah, I thought to see what everybody else thought about this, but I'm very much convinced that she needs a myocardial biopsy right now.
From an academic standpoint, I agree with you. A biopsy is what's needed. Dr. Perlini, go ahead.
Yes. I mean, to have a typing of the disease, a biopsy is fundamental, even if biopsy can also help just in case we are missing amyloid and we have something else. But there are so many unexplained pieces of the puzzle in this case that really the curiosity of looking at the myocardium is what we have to do.
I totally agree. So the key take-home message is, yes, we are in the era of non-biopsy diagnosis of ATTR cardiomyopathy, but that does not mean that endomyocardial biopsy is out of the question. When in doubt, get the tissue. Tissue does not lie. So always take a piece, and if you are suspicion, if the imaging findings do not add up and make sense. Number two, you can consider, if we have access to PET tracers, there are pan-amyloid PET tracers that are still under investigation, not FDA approved, but that will, we understand where does it bind, what it binds to, and it can be helpful, especially in these cases where you have suspicion. If you don't have access to that still, and the patient refuses a biopsy, I would consider repeating PYP, as you said, or a bone scintigraphy with a different tracer. HMDP, for example, may have different kinetics, may have different sensitivity, but a lot of smoking gun in this case.
Mm-hmm.
Any last minute, any comments? I'm just looking through the chat to see if there are any other questions. Well, it's 9:01. Let me thank all the speakers. Let me thank Dr. Juwairiya. Thank you so much. Very interesting case. Dr. Perlini, all the speakers. Thank you so much for your sharing your time, your expertise. It is indeed events like those that we advance our knowledge. We raise awareness. We learn from each other's experience. I would like to thank all the speakers, all the moderators for their time. On behalf of my co-chair, Dr. Nadia, who's on call and has been busy, I would like to thank you all. I would like to thank the audience. And until we meet once again in another educational event, please always think amyloid, and we will be in touch soon. Thank you so much, and have a good night, everyone.
Thank you.
Thank you, everybody.
Thank you.
Bye-bye.